Good evening from the Department of Endocrinology, Amrita Institute of Medical Sciences. At the outset, let me thank the Endocrine Society of India for having given me an opportunity to be part of this weekly endocrine seminar on systemic endocrinology. The topic allotted to me is hormonal control of biorhythms. I should confess that I am not an authority or an expert in this field. I had great difficulty understanding the topic, and hence if the talk doesn't live up to your expectations, please pardon me. I have tried to make it as simple as possible. So I'll be giving a brief introduction. I'll be talking about the master clock and the peripheral clocks, the entrainment of rhythms, photic and non-photic, endocrine control of rhythms, mainly focusing on glucocorticoids, menstrual cycle and melatonin, rhythm disorders and clinical applications. So someone in the past said, birds do it, bees do it, even advanced fleas do it. So everyone thought he was talking about love, but then who knows, he should have talked about circadian rhythms. So these are the plants who made man think that there is a circadian rhythm, the common shy plant which opens the leaves in the morning and closes in the night. Even if you avoid the exposure to light, you keep it in a dark room, still it opens and it closes in a circadian rhythm. So also the beans and the Drosophila or the common fruit fly, who has a rhythmic locomotor activity and vibration in the morning and mating in the evening, which follows a circadian rhythm, the organism on which maximum work on circadian rhythms are done. So it all started in 1920s with identification of these circadian rhythms. The suprachiasmatic nucleus was discovered in 1997, and the clock genes were discovered in early 2000s, and the Nobel Prize in Medicine were given to these three Nobel laureates in 2017 for their work on clock genes. So biological rhythms may be circadian rhythms, which have an intrinsic period close to 24 hours, example melatonin. Diurnal rhythms whose patterns of activity which mainly occur in the daytime, which may or may not also be circadian, for example, daily physical activity. Ultradian rhythms which occur with a period of less than 24 hours and may be as short as few minutes, for example, insulin secretion, or infradian rhythms which occur longer than 24 hours, for example, menstrual cycle. So there is a path, this is the pathway by which the circadian rhythms work. There is an input which goes into the clock. The input goes mainly into the central clock, but the peripheral clocks also receive the input, and the clock gives out output which controls the circadian rhythm. So light is a major input which controls the central clock. The peripheral clocks are controlled by other stimuli like arousal stimuli, temperature, food, and feeding. So the central clock gives its output in the form of autonomic innervations, endocrine signaling, and body temperature, and controls the peripheral clocks in the liver, in the kidney, in the heart, and all the other organs of the body. So this is how it works. So the master clock is the suprachiasmatic nucleus, which are paired structures in the hypothalamus. It functions as an autonomous pacemaker, just like our SA node and AV node in the heart. And cultured suprachiasmatic nucleus cells will continue to produce circadian rhythm even after 1 month in vitro. So it is divided into the core ventrolateral suprachiasmatic nucleus, and the shell is the dorsomedial nucleus. So the core nucleus will secrete vasoactive intestinal polypeptide and gastrin-releasing peptide. So both of which will control the rhythms associated with exercise, body temperature, heart rate, and hormone synthesis. The dorsomedial suprachiasmatic nucleus releases the AVP and calretinine, and studies have shown that people with AVP deficiency have got weak rhythms. So the endocrine control comes from the suprachiasmatic nucleus itself. Now, at a molecular level, there are many clock genes which are described in the control of these rhythms. So the main genes are the clock genes, the BMAL1 gene, the PER gene or the period gene, the cryptochrome or the CRY gene, the NR1D1, and the retinoic acid orphan receptor genes. So what it does is, during the daytime, the clock and the BMAL complexes with the E-box promoter, and activate the transcription of the PER and the CRY genes. Now, the PER and the CRY proteins make heterodimers and they enter the nucleus. Within the nucleus, there is a dynamic equilibrium of the PER-CRY complex and the solitary PER and CRY. And there are other proteins as well. When it reaches a critical level, this complex will feed back on the clock BMAL complex and inhibits its transcription. So during night, the complex dissociates and the solitary CRY binds to the clock BMAL E-box ternary complex and inhibits the transcription of PER and CRY, both by physically interfering with the transactivation as well as by interfering with the post-translational modification. This is called the transcription translational feedback loop of the mammalian circadian clock. Now, this is stabilized by another clock, pathway, which includes the NR1D1 protein, which represses the transcription of the clock BMAL complex, and the retinoic acid orphan receptor protein, which has the opposite transcriptional function to activate this complex. So the competition between these two factors will decide at what state the BMAL clock genes are. So we have secondary clocks or peripheral clocks, which are present in almost all the organs of the body. They are under the control of the suprachiasmatic nucleus, but there is synchronization at the tissue level, as I said earlier, by exercise, by arousal stimuli. It enhances the robustness of circadian signals coming from the suprachiasmatic nucleus. So it is present in the peripheral brain, heart, lung, liver, pancreas, kidney, intestine, adipose tissue, skeletal muscles, lymph nodes, spleen, bone marrow, stromal tissue, epithelial tissue, reproductive tissue. Everywhere the peripheral clocks are found. And if there is any interference with their activity, it can lead to all sorts of disorders in the respective systems. So how does the suprachiasmatic nucleus communicate with the periphery? In the brain, it communicates mainly with the paraventricular thalamic nucleus, preoptic area, posterior hypothalamic area, the tuberomammillary nucleus, hypothalamic paraventricular dorsomedial nucleus, subparaventricular zone. Then it communicates through the autonomic nervous system with the adipose tissue and the other organs, as well as the parasympathetic system through neurotransmitters, chemicals, and hormones. And this is where the hormones are involved. So we have seen the master clock and the peripheral clocks. Now we'll deal with factors which control these circadian rhythms or which entrain them. So the main entrainment factor is the sunlight. So that is called the photic seed jabber. So the photic seed jabber entrains the suprachiasmatic nucleus. There are now many other non-photic seed jabbers which mainly entrains the peripheral oscillators, and they work in synchrony. And these peripheral oscillators will control the secretion of glucocorticoids, GLP-1, ghrelin, insulin, leptin, the nutrients, glucose, fatty acids, ketone bodies. So whatever you are eating, what hormones are being secreted from the body, all of those will in turn influence the suprachiasmatic nucleus and the surrounding structures. So rhythms which are entrained by any seed jabber is called seed jabber time, and if they are not entrained by any cues, they will follow a circadian time, which is an internal time on its own without being entrained outside. So the most important entrainment factor is sunlight. So how does sunlight entrain the rhythm? Sunlight enters through the eyes to the retina. Usual pathway is not absolutely essential for entrainment. The light will be concentrated by the melanopsin containing retinal ganglion cells, which communicates through the ganglio-hypothalamic tract with the ventrolateral suprachiasmatic nucleus. The neurotransmitter involved there is glutamate. And this suprachiasmatic nucleus in turn will signal the pineal gland to produce melatonin. So the light-dark cycle induces phase shifts in circadian rhythm by acting on the suprachiasmatic nucleus, and it's synchronized with melatonin, and melatonin feedbacks on the suprachiasmatic nucleus through the melatonin receptors. Now the sleep-wake cycle is another important system which is being controlled by the circadian rhythm. So there are specific sleep promoting areas in the hypothalamus and the arousal systems in the hypothalamus. So the sleep is maintained by homeostatic processes, whereas the alertness is driven by circadian processes. So you can see there the sleep process and the alerting signals working in opposition to produce a 6-hour sleep, uninterrupted 8-hour sleep time, followed by a wake period of 16-hour period during the day. Now, if there is light exposure during the late evening and first half of the usual sleep period, the phase will get delayed. If there is light exposure at the end of the usual sleep period and in the early morning, there will be phase advances. The transition from phase delay to phase advance occurs between 4 and 6 a.m. in the morning, which is the time at which the body temperature is minimum. Negative masking means light exposure at night inhibits melatonin. That occurs both in humans and in other mammals. Positive masking means bright light at night and in the morning triggers corticosteroid release in rodents and humans respectively. So this is how the hormones control the circadian rhythm. Now coming to the non-photic stimuli, mainly the non-photic stimuli is the arousal stimuli like exercise, caffeine, social interaction, stress. So it mainly acts on the thalamus, acting through the intergeniculate tract, and the neurotransmitters are neuropeptide by GABA and endorphins. It also acts on the median raphe nucleus to produce serotonin. Both of them will control the suprachiasmatic nucleus function. Then the other important entrainment factor is food. It is called the food entrainable oscillator, which produces a food anticipatory activity. The thought about food makes you awake. How? Food induces the release of insulin. Insulin acts on the liver and the adipose tissue at the muscle peripheral clocks, which in turn act on the SCN. Hypocaloric diets resets the SCN. There also the levels of insulin, ghrelin, and leptin will vary, and it will influence the SCN. Food will release orexin and ghrelin, and it will influence the SCN. So all these will influence the circadian rhythm. Even the gut microbiota affects the circulating signals, enteric neurons, and vagal efferents that convey hunger and satiety cues to the brain, and it contributes to the rhythmic interactions between the gut and brain, thus participating in the circadian regulation of food intake. Temperature is a entrainer, but it is not strong an entrainer as food or arousal stimulant. So in short, what happens is that the endocrine feedback to the circadian clock, the brain or in the brain, the targets are mainly the lateral hypothalamus, the median raphe nucleus, and the arcuate nucleus. So from the liver and the muscle, from the white adipose tissue, from the stomach, from the pancreas, insulin, adiponectin, ghrelin, leptin, everything influences these nuclei. From the adrenals, glucocorticoids also influence this nuclei. Another molecule which is recently implicated is the FGF21, which is implicated in the pathogenesis of obesity and diabetes, and is being studies are ongoing for its clinical application in the management of diabetes. Now, next, coming to the effect of menstrual cycle on rhythms, we all know that in the pre-ovulatory follicular phase, estrogen levels are high. Post-ovulatory luteal phase, there is increasing levels of circulating progesterone, and at that time, there is an increase in body temperature. So people have studied the hormones during these two times. There is no change in the profiles of melatonin, cortisol, TSH, and prolactin during follicular phase. But during luteal phase, there is a phase delay in melatonin, cortisol, and TSH. There is a decreased TSH amplitude and an increased prolactin amplitude, and total sleep time is unchanged at different menstrual phases. So what is the clinical implication? In premenstrual dysphoric disorder and bipolar disorder, there is decreased melatonin secretion, phase advanced of circadian rhythms and body temperature rhythms, significantly advanced melatonin and TSH secretion, and therefore it contributes to the poor sleep quality and mood symptoms. So non-pharmacological therapies like phototherapy, sleep deprivation therapy have been found to be useful in the treatment of these disorders. Now coming to the second important controller of hormone, the glucocorticoids and the rhythms. So the glucocorticoids are secreted in a circadian rhythm by the interaction between central and peripheral clocks. The suprachiasmatic nucleus innervates the paraventricular nucleus from which where rhythmic CRS will is released, which triggers the secretion of ACTH from the pituitary. The autonomic innervation of the adrenal resets the adrenocortical clocks, regulating the sensitivity of the steroidogenic machinery to the ACTH. And this synchrony between the HPA and the adrenal ACTH gating results in high amplitude and robust circadian glucocorticoid rhythms. So the 24-hour profile of ACTH and cortisol is an early morning maximum, declining levels throughout the daytime, quiescent period at midnight, abrupt elevation during late sleep, followed by the early morning maximum. Now, how does it affect the circadian rhythm? Glucocorticoid receptors are ubiquitous except in the suprachiasmatic nucleus. The proximal promoters of the PER genes and the other genes will contains glucocorticoid response elements, so which are activated by the glucocorticoids, and they will reset the phase of the transcription translational feedback loop, which I described initially. So when there is a lot of steroids around, as in steroid therapy or in stress, the NR1D1 is the expression, the glucocorticoid will suppress the expression of the NR1D1 via E-box in the promoter through a protein-protein interaction without direct binding of the glucocorticoid receptor to the DNA. This process is called tethering, and this is very important in the control of the circadian rhythms. This is how glucocorticoids control circadian rhythms. So this is the usual profile of glucocorticoids. At the onset of sleep, the cortisol levels are minimum. If you open your eyes in darkness, you get a surge in cortisol. If you open your eyes in dim light, you see your WhatsApp message at midnight, you get a higher level of cortisol. You wake up in the morning and you wake up in a dim light. That is, before the sun shines, you wake up and look at your mobile, the cortisol levels are maximum. But if you transition from dim light to bright light, the cortisol levels are minimum. So it is always advisable to open your eyes into bright light. So if you are sleep deprived, the high glucocorticoid will remain as such even in the late afternoon. This will again cause nocturnal awakening, which will lead to high glucocorticoid levels, thus causing a vicious cycle of high glucocorticoid levels. So the clinical implication is that in Cushing's disease, Addison's, and in chronic stress, there are many sleep and circadian rhythm disorders. When we are replacing steroids in Addison, we should try to match this circadian rhythm of. Well, I was talking about melatonin. Can I continue from here?
Please do. That's correct.
Thank you. So melatonin is synthesized mainly from the pineal gland, but levels in the GI tract are 10 to 100 times more than that found in the blood. It is also secreted from the retina, the brain, the bone marrow, and the other blood cells. So it starts getting secreted at around 8 p.m. It peaks its level at around 3 a.m. to reach lowest level at around 7 a.m. So it is synthesized from tryptophan by the action of tryptophan hydroxylase, which converts it into 5-hydroxytryptophan, and it gets decarboxylated to form serotonin. Serotonin is acted upon by aryl alkylamine N-acetyl transferase to produce N-acetyl serotonin, and N-acetyl serotonin methyl transferase will convert it into melatonin. Now, how the pineal gland is innervated? From the suprachiasmatic nucleus, as I already told, through the retinohypothalamic tract and the gangliohypothalamic tract, it gives input to the parvicellular hypothalamus, paraventricular hypothalamus, and then it innervates the sympathetic preganglionic neurons in the intermediolateral cell column of the thoracic regions of the spinal cord, which innervates the postganglionic neurons in the superior cervical ganglion, and ultimately supplies noradrenergic innervation to the pineal gland. So it is the beta receptors which are present in the pinealocytes, and the molecular mechanism is it increases cyclic AMP and the protein kinase C. So light inhibits norepinephrine release from the superior cervical ganglion, and thereby it inhibits melatonin synthesis. So melatonin acts on 3 receptors, the melatonin receptor 1, 2, and 3, otherwise called 1A, 1B, and 1C. 1 is present in the pituitary and the suprachiasmatic nucleus and retina. It is a G protein coupled receptor which controls the circadian rhythms. 2 is mainly found in the retina and the peripheral brain. It is involved in phase shifts. 3 is in the brain and peripheral tissues. It actually is a quinone, it acts through quinone reductase 2 and is involved in cellular detoxification. So the main role of melatonin is to control the internal clock, that is the suprachiasmatic nucleus, through the melatonin receptor 1. It acts as the clock resetting signals, and it helps the body to adapt to the environment. So you wake up early in the morning, your cortisol increases, you have your food, you will feel like having your food to get some energy. All these are based on the melatonin secretion, which comes down in the early morning. So it synchronizes the peripheral oscillators in all the organs of the body, the adrenals, the pancreas, the liver, kidney, heart, lung, fat, gut, etc. It is also involved in the regulation of the reproductive axis. It keeps the GnRH axis suppressed. So there is absence of melatonin, you can get precocious puberty. It is involved in fetal development. It is involved in detoxification. That is why it is involved in the pathogenesis of cancer. It is involved in cardiovascular and immune system function, making it a part of pathogenesis of cardiovascular diseases and autoimmune diseases. And it is also involved in maintaining the body mass and the bone mass and making it a pathogenic factor in diabetes, obesity, and osteoporosis. So what all effects melatonin has on the rhythms? It will increase the sleep, it will decrease the body temperature, it will increase the gradient of the distal and the proximal skin temperature, and it increases sleep. So impaired melatonin secretion is seen in primary degeneration of the autonomic nervous system, diabetic neuropathy, Alzheimer's disease, and certain drugs like beta blockers, clonidine, naloxone, and NSAIDs. In diabetic autonomic neuropathy, even if there is no frank autonomic neuropathy, and even in subclinical autonomic neuropathy, we will get sympathetic denervation of the pineal gland, resulting in sleep disorders associated with diabetes. So diagnostic use, it is measured using LCMS in saliva or blood in dim light 2 weeks to block melatonin production. That is called dim light melatonin onset. Normal levels in the blood is 80 to 120 picogram per ml. It provides a unique and immediate measure of the phase of the suprachiasmatic nucleus, and is the most accurate clinical tool available to study circadian clock in humans. So therapeutic use of melatonin they are used, as Lakshmi mentioned in few of the questions. It is used in phase shifting and resetting circadian rhythm disorders. It is used for jet lag. It is safe when it is used for less than 3 months. It doesn't increase the slow wave sleep time. It is the first line pharmacological treatment according to American Association of Family Physicians for the treatment of insomnia, but it is not FDA approved. Many formulations are available: IV, oral, immediate release, extended release, combined formulations. Dosing is not well defined. We give whatever tablet is available in our locality. In our locality, 3 mg tablet is available, but with varying strengths from 0.1 to 10 milligram is available. It is administered up to 2 hours before bedtime. Melatonin receptor agonists ramelteon and tasimelteon are FDA approved for insomnia. Elimination half-life of oral is 1 to 2 hours, and it depends on the formulation. It is metabolized mainly in the liver. It is relatively non-toxic, but long-term use can lead to drowsiness, daytime sleepiness, headaches, and nausea. There is no evidence to suggest that people develop tolerance to melatonin. Now, coming to the rhythm disorders, most of these have been described by Dr. Lakshmi. So jet lag disorder is caused by rapid travel across more than 2 time zones. Eastward travel causes more severe symptoms than westward travel. So if possible, travelers should gradually shift their sleep-wake schedule before travel to approximate that of their destination. And after arriving at the destination, they should maximize exposure to daylight in the morning and exposure to darkness before bedtime. Shift work disorder, the problems will be related to the frequency and magnitude of the shift changes, number and length of consecutive nights work, and frequency of counterclockwise changes or sleep advancing changes. Fixed shift work is preferable. If you are rotating, you should go clockwise. That is, initially you should take day, then evening, and then night. While you should maximize light exposure while awake and minimize while sleeping. Then there are altered sleep phase disorders, the delayed sleep phase syndrome, which most of our adolescents have because of the increased screen time. Patients consistently go late to bed and awake late. So treatment is, you can try melatonin 4 to 5 hours before the desired bedtime, progressively earlier rising plus morning bright light, or progressively delay bedtime and awakening time by 1 to 3 hours until the correct sleep and wake times are reached. Advanced sleep phase syndrome is seen in older people, early to bed, early to rise. Treatment is by giving bright light in the evening and light preventing goggles in the morning. Non-24-hour sleep wake syndrome mainly seen in blind people. They sleep and rise whenever they like. So circadian misalignment is associated with metabolic ill health. There is higher incidence of insulin resistance, hypertension, and heart disease, higher mean arterial blood pressure, higher circulating levels of glucose and insulin, lower levels of leptin. Maximizing exposure to natural daylight with corresponding minimization of light exposure at night will improve the circadian health. Eating meals within a limited window of 24-hour cycle, which is called time-restricted eating, which equates to our intermittent fasting nowadays, or at least avoiding meals in the late evening is very good for metabolic health. Now, there is a term called chronotherapeutics, where the clinical efficacy of the drug depends on the time at which the drug is taken. So more studies need to be done before you can make this practical. And then finally, this is involved in the timing of hormone measurements. Dr. Lakshmi has mentioned in her slides. Cortisol is mainly circadian rhythm. Growth hormone and prolactin increases with sleep. TSH, there is evening elevation, nocturnal inhibition by the sleep. And if you are sleep deprived, there is increase in nocturnal TSH. And aging also affects the hormones. Old age, there is a higher nadir of the cortisol. Then there is the low growth hormone and prolactin. And there is a significant advance in melatonin and a lower levels of melatonin, which is associated with decrease in slow wave sleep in aging. So exposure to bright light and physical activity will improve the circadian rhythms in old age. So to summarize, growth hormone, we don't have any random growth hormone measurement, doesn't have any clinical significance except in unequivocal high levels in acromegaly. Thyroid function, TSH levels do vary, but T3, T4 levels don't vary much, so you can draw at any time of the day. Reproductive axis, we all know, but other hormones in relation to reproductive follicular phase, luteal phase are not clinically significant. Testosterone, you always measure in the morning. Cortisol, there is a diurnal rhythm. And prolactin, you always measure in the late morning because early morning, the nocturnal peak may still remain. Thank you for the patient listening. Happy Vishu from all of us in Kerala. Thank you.